Good morning. I'm going to broadly agree with Philip in a PowerPoint-free presentation, I'm afraid. But just to start off with what the skeptics say, I think quite a lot of people say it's almost a sort of category mistake to ask what the big society means, because the big society was a political slogan. It was meant to be capacious, it was deliberately vague, and was not designed as a policy or governing program. There are a few elements like citizen service, big society bank, and so on, but there was no, as it were, plan set out in manifestos and so on. Others would say it's inappropriate in a way to pose the question this way for health because, of course, the NHS has never been the state monolith that it's sometimes portrayed as. It's always been as much a flotilla of thousands of small businesses, GPs, pharmacists, and so on, always depended on hundreds of thousands of volunteers, always depended on 6-7 million carers, and always existed alongside a very strong and pretty rich voluntary sector in the UK. It's also said to be perhaps an inappropriate question because for the last 10 years at least, Britain has been almost unique in the world in having a very active set of policies to build up the voluntary sector and social enterprise in health. Over 30,000 third sector organisations contracted and commissioned, a whole host of rules and rights, supports for spin-outs like Surrey, investment funds for social enterprise, personal budgets. Almost every single element, as it were, exists already and has been experimented with in the last few years. And that's why, say, the skeptics say what's new, what's good about the big society in health isn't new, and what's new about it may not be good. That said, I actually think there is a really important underlying set of issues here and questions which I think the health world still hasn't really faced up to. At one level, there's a very obvious point which almost every sort of health review ever sort of points out, that citizens will have to take more responsibility for their health in an era where long-term conditions drive healthcare costs. But there's also, I think, a slightly different issue which isn't always sharply focused on, which is the question, how does any health system tap into what I call the collective intelligence of itself and of its society to come up with better solutions? The knowledge of the nurse, the doctor, as well as the sort of clinical experimenters, but also the knowledge in the heads of patients, communities, and so on, in the sorts of projects which Philip described. And what I want to do is just suggest where those two questions may intersect and what that might mean for the next few years. My sort of work on health tends to oscillate between sort of the helicopter view of looking at things through the lens of governments and then sort of looking at things from the other end, from often quite small projects at the grassroots level. I would just make one comment, as I now work for governments including the US and China at one scale and sort of Finland and Singapore at the other, that all claims of economies of scale in any aspect of public services are almost certainly wrong. And almost all the places doing things best are very small, and indeed smaller than most experts in Britain think is economic. But that's a discussion perhaps to come back to later. Big societies are not particularly desirable. What I want to talk about, though, is the, in a sense, the other end of the telescope and the fertility and creativity. And the organisation where I now work has, for 20 or 30 years, been developing new sort of patient-led models of healthcare, gave birth to the Patients Association, the College of Health, Healthline, which was the first phone-based diagnostic system. And we now have a team both designing and working with lots of ventures of the kind Philip described, and some people in this room are involved in it, including Norman Warner, who will be talking later, trying to design new models around MS or dementia or heart disease in ways which embody what should be the medium to long-term direction of change for public services. We have things called social entrepreneurs in residence located within PCTs, and the first one now in a university, just announced this week, in fact. And we also host a team advising the SHA regional innovation funds, and therefore seeing thousands of applications from nurses, doctors, social enterprises, and so on, showing innovative models of improving health gain, productivity, and so on. One very striking observation which comes from doing that is that compared to the very mature, very well-funded systems for clinical research, medical technology and so on, we still have much weaker, much less mature systems for tapping collective intelligence around service design, organizational design, ways of mobilizing the patient, the community, and so on. And the links into commissioning still remain weak and underdeveloped. But the main point I want to make is a slightly different one. What strikes me again and again from most of the best models coming up from within the NHS and from outside, offering significantly better ways of dealing with things like, say, heart disease, cancer management, and so on, is how many of them are neither purely clinician-led, doctor-led and so on, or purely, as it were, big society, patient-led and so on. Nearly all the best models are hybrids, which combine often more specialist clinical knowledge, often use more of certain kinds of technology, but alongside better ways of mobilizing the individual patient, their family, their friends, and their community. And this is particularly striking in the territory which I'm spending quite a lot of my time on at the moment, which is reducing hospital readmissions, as I'm sure many of you in this room are. Where obviously there's quite a strong policy thrust with targets and funds and so on. And what's interesting is if you set the task of reducing hospital readmissions by 30, 40, 50%, whatever it may be, some of the solutions as it were, start in the hospital and move outwards, like virtual wards, which Nuffield has been one of the promoters of. Others almost start with social care and try and link into health, and various county councils have community navigators and all sorts of new roles trying to join things up. And some start in the third sector, various projects of Age UK and others. All of them are in some ways trying to solve the same problem, as how do you tie together a mix of different kinds of service, some very clinical, some very informal, and some about, as it were, social care, reablement, and so on. Now this basic point I'm trying to make about the big society, that in the health world it will usually involve hybrids and combinations rather than alternatives, also applies in what I think may be one of the most important territories we have to think about, which is data and knowledge. This is coming to the fore in one quite small project which we're hosting called MyDex, which started from the question, could you pass power over personal data out from big companies, big government, into the hands of citizens, so they could control their own data, see if it's accurate, see that it's not being sold, lost in CDs, left in car parks, and so on. And there are 3 trials underway now mixing local authorities and commercial providers of this model, which puts control in the hands of citizens, who then lend their data to public agencies, utilities like BT, and private companies. Interestingly, this is about to be applied to health as well, where the Red Book can be turned into a MyDex model, where the parent, their Red Book for their child, is online, allows them to track different kinds of data to see how their child compares with other children, and so on. And is one of many examples of much cheaper, often quite low-tech solutions, which are ground up and achieve better results at dramatically lower cost than the old generation top-down EPR and other kinds of programs. But again, they only work if you get the right partnership between the citizen, the family, the patient, and the GPs and the system, rather than the data being used by one against the other. And here, I think, is a much bigger issue, and I want to really conclude with really a slightly different lens on what the big society might mean if we look 10 or 20 years ahead, and the other side of the interesting dynamics of reform, experimentation on funding systems and so on, which I'm sure we'll come back to again and again in the rest of the day. But I want to focus on something else. We've talked a lot in recent years about putting the patient at the centre of the health system. It's been the rhetoric of health ministers for as long as I can remember. But in fact, I think that's a slightly wrong articulation of what the challenge is. I think in most of the things we'll be talking about today, the question is, how do you combine an empowered patient with an ecology of knowledge, a growing ecology of knowledge about what that patient might do for themselves, but also what might be done for them by a hospital, a doctor, a provider, and so on. And no patient really wants to be completely at the centre of the health system, because no patient actually has the best knowledge about what to do to cure themselves, treat themselves, and so on. There's a strange gap between the rhetoric and the reality. And I think one of the biggest challenges in all health systems, and the key to really creating an enabled, empowered, responsible population taking much more sort of care of their own health, is what you do to create a system of knowledge which provides the best, most reliable, most meaningful knowledge at all the different points of the system where it's needed. From the diabetic waking up in the morning, to the child wanting to look after their parent with early onset dementia, to the GP, the nurse, the hospital doctor, and so on. And in a way, what this is a question of how do you organise a knowledge commons? How do you organise this collective wisdom about how health works? And interestingly, Britain has probably more building blocks towards where that could be in 10 or 20 years than anywhere else in the world. We have things like NHS evidence. We obviously have NHS Direct. We have NICE, which no other country has a NICE, and many are trying to copy it in other fields. We have global tools like Cochrane Collaboration and so on. We have commercial ones like Boots, WebMD. And we have quite a few coming up from civil society, like Patients Like Us or Patient Opinion, all trying to provide different kinds of knowledge to help people make smarter decisions, either about their care for themselves or about their care for others. And yet, all of you in this room will have observed, perhaps in your own lives or in your friends' lives, that when a health event happens, when, let's say, a parent is diagnosed with dementia or a friend is diagnosed with a cancer, the common experience is of confusion and fear, trying to work out what to believe, what to know, how should I change my behaviour, which treatment should I have? And since this is the paradox of the daily health experience of society, is on the one hand, this massive accumulation of knowledge, and on the other hand, ever greater fear, anxiety about how to navigate that knowledge and make it useful. And I think if we stand back and ask the question, how could you orchestrate your knowledge commons in a different way, we come to some quite interesting possible answers. On the one hand, we clearly need that knowledge commons to be based on rigour, about what actually is evidence, what is knowable, and we need a structure of authority to determine what actually counts as knowledge. And yet, we also need that to be sophisticated, about when RCTs are in fact meaningful and not liable to be overturned. And any of you who know that health evidence in detail will know how much less solid it is than I think many people outside the health world believe. Secondly, though, it's clear that what people need is a range of different kinds of knowledge, not just the formal knowledge of, say, medical trials and so on, but also experiential knowledge. How do you manage pain? Social knowledge. We know far more about the dynamic relationships between, let's say, isolation and loneliness and health than we did in the past. And that's a different kind of knowledge which is relevant to people trying to treat conditions or help overcome them. There's knowledge about environmental shaping. I mean, for me, the biggest message of all the behaviour change literature is, in fact, actually the nudge arguments are largely wrong. The biggest impact on behaviour comes from shaping environments, not from little marginal nudges to encouragements and incentives, things like banning smoking. But the key point is there's a whole range of kinds of knowledge which have to be orchestrated. And if you simply have one domain of purely, say, clinical knowledge and everything else is treated as inappropriate, you actually exacerbate the confusion that people experience when faced with a health event in their own lives. You then need, and this is even more challenging, to be able to communicate what the degrees of certainty are about any kind of knowledge. There is a continuum from very strongly proven knowledge about health to absolute quackery, and in between, lots of grey areas. Grey areas about 5 a day. Grey areas about all sorts of different treatments at different times for different conditions. There's a lot of rather interesting work around in the scientific community worldwide on how do you actually present uncertainty in digestible ways for the public. How do you show the balance of opinion on an issue like, say, flu vaccinations or climate change, using visual descriptions which are honest, as it were, about the fact that there's a continuum between the very proven data and that which is in fact liable to cause you harm. And clearly any knowledge commons has to communicate in that way to the public. And then finally, you need encouragement for and support for the people who will interpret all of that knowledge, which will be GPs, will be health coaches, will be nurses, will sometimes be parents and spouses, and so on. We know that the supply of knowledge doesn't on its own create demand for it. In small ways, my own organisation is trying to grapple with some of these things. We're launching in 2 months' time the first branches of the Citizens University, announced by Mr. Cameron last autumn, which will provide short courses in high street locations to the public on a whole range of issues, but they include things like first aid skills, home doctoring skills. Our focus groups show huge demand from the public for simple courses to learn a little bit more about how to look after their kids, and lots of encouragement from the GPs to do that to reduce pressure on the GPs, but also courses like Support My Parent. So if your parent is diagnosed with dementia, a 2-hour course to help you navigate how to be a better a child and supporter for them. Or if you're diagnosed with type 2 diabetes, the short course where you learn how you should manage your condition, which websites to use, which other people to draw peer support from as well. We've got another project in a very different lens, Maslaha, which won an award last year, trying to integrate health knowledge with theological knowledge from imams and Islam. Again, it's a different kind of way of thinking about the knowledge commons, but making it relevant for a community which the health service still finds it quite hard to engage with. In a way, the sort of simple message I'm trying to make here is that although we have to navigate the very difficult, very messy process of reform and changing funding structures and so on, and we still primarily think of these things through an economic lens, my guess is we not only need to think through the much more sort of social and sociological lens, which Philip talked about, but if we're looking over 10, 20, 30-year time horizons, we need to look through the knowledge lens, and thinking about the structures and orchestration and incentivization of knowledge, I think will become as important to every health conversation as talk about money and tariffs and incentives is today. And we're fortunate in that the UK is very well positioned in having such strong institutions in this space. And we're also lucky that it may be that what is the right thing to do internally in the UK may also be one of the best things we can do for the rest of the world. Just as creating a BBC, which was really good for British citizens, happened to also give the world an extraordinarily valuable public service source of knowledge as well. And I mention all of this because we happen to be hosted here by an institution, Nuffield, which is probably better placed to advance this agenda than any other. Thank you.